muted feature to have optimal audio conditions. So please know that via conference call, that part will not be interactive, but when we get to the question and answer portion of our time, we will be using the chat feature, which you'll find in your right margin of the WebEx program. So let me do that now.
To place all participants are now in listen-only mode.
Okay, so thank you. We are excited to be able to present this morning Arlene Lovejoy and Sarah Swindle speaking on G-Tube Care. And we will be starting first with Arlene on G-Tube Care, and that will go for about a half hour. And then we have Sarah Swindle speaking on enteral feeding, an overview and practice guidelines. And then from 1:05 to 1:30, we will take question and answers. And again, we will be using the chat feature in WebEx. And if you need to expand that, you would do that on your line on your right margin. For those of you that are only participating via conference call and are not connected via WebEx, please send me an email at ohinojosa, which is ohinojosa10@gmail.com, so that we can capture your attendance and that we might be able to follow up with you with a post-webinar survey about your participation. So we thank you for that. So without further ado, I'm going to turn it over to Arlene. Thank you, Arlene, for being with us this morning.
And thank you for inviting me. I was really looking forward to this. Just for background, I work at LA County, USC, and my email address is here on the slide. I will also make more material available for you through the webinar afterwards. I work in the newborn intensive care unit, but I've also done pediatrics and a little home care too. So we're going to talk about what it takes to take care of a G-tube. This first slide has a picture of what we call a G-tube button or a Mickey button. And you can actually see that this baby has had some kind of surgery because there's a surgical scar, and it looks pretty benign. But let's get on to what it starts with. Now,
it takes a couple of seconds for it to.
Okay.
You've just been made presenter, so go ahead and try.
Now I can.
You're using the arrows?
I'm using up or down, or that's what I did.
We're using
Arlene, do you want to talk a little bit about your bio while they're getting that up?
Sure. I have worked for 30 years with newborn intensive care. I have helped a lot of families get used to the idea of a G-tube. It takes a long time to get used to the idea of a G-tube. And in my own personal situation, my father had to have a G-tube, and I was the one who actually advocated for it. The facility that he was in was, shall we say, dragging their feet a little bit, and I had to be the patient advocate, which is what you have to do. And once you've seen it work and get over the image that changes of your baby in your mind, it really is a facility that you will want and will share your experience with others. Okay, common parts of all kinds of G-tubes, and this is kind of a line drawing of a percutaneous endoscopic gastrostomy tube. Okay, it's a peg. And you will see that there'll be some kind of anchor, which is usually a balloon or a mushroom tip, inside the stomach cavity. And then the rest of the tube will extend out through the muscle and tissue with some kind of external bumper or taping that will secure it there to the outside of the stomach wall, the outside of your abdomen, and then some kind of extension going out with an adapter to whatever feeding pump you have or whether you're doing a gravity feeding. And then I wanted to also mention that a lot of tubes come with a tubing clamp, which is a hard plastic thing, and I want to talk later about using the easy way, which is a rubber band. Now, usually when you get a tube in a pediatric patient, and that's a newborn or a young pediatric or even older pediatric patient, you get what they call a Foley catheter, which was originally designed many, many, many years ago as a urinary catheter. It still is used for that. But because we don't have a lot of patients in our age group that require G-tubes, this is usually the first thing that's used. And it's very simple because it's just a long tube with a balloon. They come in a variety of diameters, so it depends on what size your baby is and how big the surgeon makes the opening or stoma. There are adaptations we can make to this by adding our own tape and bolster and connecting devices, and I'll talk a little bit about that. This is what you, quote, graduate to with your child. The Mickey button, which is also called, I love this terminology now, instead of a button, they're calling it a low-profile gastrostomy feeding tube. In other words, it's pretty flush with the abdomen and doesn't poke out or hang out of a t-shirt or poke through any clothing. It has an internal balloon, a one-way valve, and then it varies in diameter and length so that it will lay flat against the external abdomen and be right inside. The balloon will sit right against the stomach wall on the inside. It has a one-way valve, so it usually doesn't leak, but you can use the little snap closure across it in case it does start to leak just a little bit. But this you'll get in your surgical clinic follow-up visit. All right, common problems. Our usual fear once we get something put or changed in our child is what happens if it comes undone or pops out. In the first couple of weeks, it is considered a surgical emergency. So if your baby or your child gets the tube put in a surgical clinic or in the hospital and then goes home before that 2-week magic period of maturity, if it pops out, you really ought to load the baby up in the car and take them to urgent care or a pediatric emergency room to have the tube placed. The reason is that it takes some time for that channel from the outside abdomen to the inside to mature and hold its shape. Before that, the muscular tissue that's right around the tube may shut, and then it may be difficult. They might have to put the baby under a little sedation or anesthesia to actually put the tube in. After 2 weeks, roughly 2 weeks, it's considered a mature tube, and you yourself are able to put the tube back in, especially if it's a Foley. Foleys are very simple to put in, and most of the time it's been my experience that surgeons will give the family a Foley catheter tube as a backup to whatever device they put into the stoma. So if the one that's in there falls out, you have the Foley to put in. Doesn't require anything extra than maybe a little KY jelly. Now, as the child gets older, they get interested in this thing hanging off their abdomen, and they go grabbing for it, or inadvertently they move while they're hooked up to a feeding tube and they become disconnected or it pulls out. A couple things we recommend. In the neonatal unit, we say onesies, and I'll show you a picture of what one of those looks like. And on older kids, you can actually purchase from a medical supply company, and I have that listed here in my resources, stockinette. This is an orthopedic supply which is used for casting, but comes in a variety of diameters that'll stretch. You buy it and cut a little length, and it becomes like a little undergarment over the G-tube, a little less access to that thing that looks so attractive to them. And here's what stockinette looks like. You can buy this from the Comfort Company. There's the website listed right there. Probably some medical supply stores carry it, but most of us are homebound with our